Good morning, everyone. My name is Adam Levy. I'm an MS3 here at the University of Miami, currently on my sub-I. And today I'll be discussing a few projects pertaining to enhanced recovery protocols within cranial neurosurgery. So first, to introduce ERAS, enhanced recovery after surgery is a term first coined in the 90s by groups in Europe for elective intra-abdominal surgery. These protocols work to improve patient care at the preoperative, intraoperative, and postoperative stages of an operative admission with the ultimate goal of hastening recovery and improving patient experience. There's 4 core tenets of ERAS, the first being to focus on all stages of the operative admission, the second being interdepartmental collaboration, the third being use of novel technologies to enhance recovery time, reduce morbidity, and reduce pain, and the fourth being continuous data-driven process improvement. These protocols have been shown to reduce preoperative stress, reduce nosocomial infection rates, reduce hospital-acquired iatrogenic injury, improve patient satisfaction, reduce hospital length of stay, reduce admission costs, and increase early mobilization. Since the year 2005, an official ERAS society has existed for the auditing and approval of ERAS protocols across a number of subspecialties, ranging from obstetrics to general surgery, and more recently to neurosurgery. Regarding ERAS in neurosurgery, the field of neurosurgery has really witnessed a boom in the last decade in development of these protocols, largely pioneered by Dr. Wang and others with his early work in ERAS for lumbar fusion utilizing MIS-TLIF in 2017, which inspired several other branching and follow-up studies, many of which happened here at the University of Miami, leading up to the official consensus statement here for perioperative care in lumbar fusion, being the one and only ERAS protocol approved by the society currently for neurosurgery. With that being said, cranial neurosurgery has recently begun to follow suit that have spined with fast-track admission protocols, such as the ambulatory biopsy protocol proposed by University of Toronto, University of Miami with their same-day discharge following brain tumor resection and craniotomy, and most recently our proposal for an ERAS protocol following laser interstitial thermal therapy, or LITT. So I'm going to first begin by discussing kind of the journey and what everything got going at the University of Miami. The first project here was that proposed by Angela Richardson. It was a retrospective study looking at predictors for successful discharge following craniotomy on post-op day 1. This was published in 2019, and it was a retrospective review of 424 craniotomies between the years of 2011 and 2015. A number of clinical variables were investigated, including demographics, tumor characteristics, operative details, and with the ultimate goal of finding predictive variables for post-op day 1 discharge following craniotomy. Variables found to be significant on uni and multivariate analysis included male gender, low preoperative MRS score, low frailty index score. Those were all significant positive predictors for early discharge. With left-sided lesions, posterior fossa tumors, large tumor diameter, and the need for CSF diversion, all being negative predictors for post-op day 1 discharge following craniotomy. Kind of following suit with the goals of ERAS, this protocol in this retrospective study showed a significant difference in 30-day readmission rates between those discharged on post-op day 1 and those discharged at later dates in the admission. Similarly, there's a significant reduction in DVTs and thromboembolic events when compared to those who had traditional admissions. So the positive results of that original study inspired our pilot same-day discharge craniotomy study, pushing the needle forward here. This was a study done by Freddie Vallejo, published in 2022 in Neuro-Oncology, Journal of Neuro-Oncology. This was a prospective study looking at 37 craniotomies using these inclusion and exclusion criteria derived from the Richardson study. The inclusion criteria briefly for this study were tumors in the supratentorial area, ages 16 to 85, ASA less than or equal to 4, KPS greater than or equal to 70, and cases excluded were those with diameter over 4, estimated blood loss over 300 cc's, estimated uptime over 3 hours, and BMI over 35. And again, this criteria was derived from the Richardson study. So ultimately, among the 334 consecutive craniotomies performed in the year of 2020 to 2021, 37 were ultimately selected using this criteria. 32 of those were successfully discharged on post-op day 0, and 5 of those were discharged within 24 hours of surgery, converted to a traditional inpatient course, but again, discharged at 24 hours. And it's important to mention here for the purpose of the next study that at surgeon discretion, clinical discretion, at any point along the admission track, the attending surgeon could choose to convert patients to a traditional inpatient course, including at the preoperative stages, even if they did, in fact, qualify as defined by these criteria here. So briefly, this is just the operative workflow here. Patients would arrive the day before surgery. That's a practice shown to reduce preoperative stress. The patient would be taken for the first case the next day. Following surgery, they're brought to the PACU for 3 hours, followed by the neuro ICU for 3 hours. In that time, they would get post-op imaging. And then if deemed stable, that is hemodynamically stable with no fever and deemed safe for discharge home by PT/OT, they would be sent home shortly after that 6-hour period, if possible. Again, outcomes of this study were again promising. 5 of the patients of the 37 were converted to traditional inpatient courses, but again, all were discharged within 24 hours of surgery. There were 4 total readmissions within the 30-day postoperative period, one of those being an immediate admission. However, none of these were neurosurgically related admissions. Some examples here, abdominal pain, constipation, headache, and new unrelated back pain. So the strong results of that study inspired a follow-up study to the pilot, again, another prospective analysis in the next year of same-day discharge patients. The goals of this study were to query the absolute BMI criteria stated in the first study. The reason for this is that evidence against high BMI patients, specifically for neurosurgery or supratentorial lesions, is not very strong. There is some evidence that high BMI can lead to things like shunt migration, and it does increase the risk of postoperative complications following cerebellopontine angle tumors. However, there's no strong evidence suggesting this is an absolute risk factor for supratentorial lesions, aside from the fact that there is an increased risk going under general anesthesia with high BMI patients. The second goal of this study was to quantify that surgeon discretion that I had mentioned earlier, in which qualified patients could be discounted at the clinical kind of gestalt of the surgeon admitting the patient. The ultimate goal of these 2 objectives is to ease the adoption of this protocol at other institutions. And so to do this, we developed a clinical scoring system, sort of an easy tool that would allow physicians to more comfortably admit patients using a same-day discharge protocol. So here's a brief flow chart of our patients admitted throughout the year. We included 31 patients. 3 of those were converted to traditional inpatient admissions, while the rest of them, 28, being discharged successfully on postoperative day 0. Concurrently, 59 patients were qualified as defined by these criteria, but were ultimately not included at clinical discretion. So outcomes again here. It's important to say here, the mean operative time was significantly lower for same-day discharge patients. The craniotomies here taking about an hour and a half compared to 2 hours for non-same-day discharge, but qualified patients. Outcomes, however, were, again, very promising. ER visits were low, about a 13% ER visit rate among those who had same-day discharge, none of those being neurosurgically related, with good median KPS at first follow-up. And again, those 3 patients that were converted to traditional inpatient admissions, 2 of them were due to slow emergence with anesthesia, 1 of them for diffuse weakness, which improved after roughly 4 hours following surgery. So looking at BMI, we were happy to see there was no significant difference between those with BMI over 35 and those under regarding any of our outcome variables. So no significant difference in ER visit in the post-op period, nor neurosurgery admissions, nor in median postoperative KPS at first follow-up. Looking at the differences in selection variables, so comparing those who qualified and were selected and those who were qualified and not selected, 4 significant variables were found on both uni and multivariate analysis. The first being negative predictive value for previous treatment of the intracranial lesion. The second being left-sided lesion, again, similar to the Richardson paper. and our one positive preoperative predictor being extraaxial pathology. And lastly, our third negative predictor being high tumor volume. So using all of the variables significant on multivariate analysis, we pulled them into their own binary logistic regression and used relative odds ratios to define weights for our scoring system. Our scoring system can be seen here at the bottom of the screen. Essentially, it's simple in the fact that a patient would qualify as defined by the inclusion-exclusion criteria, ignoring the BMI. From that, clinical variables can be analyzed here. Any patient with left-sided lesion or previous treatment for their lesion were deducted a point, and those with a preoperative volume of less than or equal to 11.75 cubic centimeters, or those with extraaxial pathology were given a point each for those two variables. And we then tested this scoring system on a combined cohort. So this included all the patients from the pilot study, as well as those from the follow-up study, and those who were qualified but were not selected in the follow-up study. And we were happy to find that scores of +1 and +2 were significantly predictive for successful same-day discharge. So this wasn't just looking at those who were selected for same-day discharge, but those who were selected and ultimately discharged on postoperative day 0. Likewise, those with a score of -2 or -1 were shown to have negative, or were unlikely to be discharged at postoperative day 0. And this model and scoring system here was found to be significantly predictive with an AUC of 0.83. So moving forward, conclusions regarding this project, the scoring system does require external validation, either through a prospective study here at the University of Miami, or through other institutions that are currently performing same-day discharge or outpatient craniotomies, with the goal of incorporating that third tenet of ERAS and using novel technology and minimally invasive techniques. We could propose the idea of performing minimally invasive craniotomies for deep lesions with Vicor under the same-day discharge protocol as a thought for future projects. And we'd like to continue to observe outcomes with this protocol proposed. So next, very quickly with my time left here, I'm just going to discuss another retrospective study that we performed here at the University of Miami. This was published earlier this year in Neuro-Oncology Practice. We did a retrospective review of all lit patients who underwent lit for brain tumor ablation between the years of 2015 and 2021, ultimately including 184 consecutive lit cases. We looked at intraoperative, preoperative, and postoperative sort of workflow, described that, and investigated outcomes. We did find that we had favorable outcomes compared to the literature, which I'll discuss in the following slide, which prompted us to perform a focused literature review regarding enhanced recovery protocols in conjunction with our colleagues in anesthesia, which I'll be discussing in just a moment. Briefly regarding our demographics here, our lit patients were predominantly supranatorial lesions, more so female, with a mean age of 60 years old, and they were a very stable preoperative patient cohort of KPS median of 90, MRS of 1, modified frailty index of 1 as well. So this is just a brief glimpse of the current workflow we utilize here at the University of Miami. Similar to the post-op day 0 brain tumor workflow, patients are admitted the night before. Prior to that, we aim to optimize them, recommend things like smoking cessation, alcohol cessation, nutrition assessment when possible, and anesthetic optimization by anesthesia. They're kept NPO for 8 hours prior to surgery. The night before, they're prepped with a Hibiclens bath and started on SCDs for antithrombotic prophylaxis. The patients are given antimicrobial prophylaxis leading into surgery, and then prepped again with chlorhexidine in the OR. Other things sort of in the ERAS realm that we did for lit currently at University of Miami include postoperative nausea and vomiting prophylaxis, that sort of thing. Essentially, the first stage of this surgery, I know everyone is familiar with the surgery here in this talk, but the first half is done in the operating room. The second half is then done in the MRI suite where the actual ablation is taken care of. Postoperatively, they start on DVT prophylaxis, steroid prophylaxis, and fluid de-escalation with postoperative imaging within the first 6 hours. So with this current workflow, we had satisfactory outcomes with a median length of stay of just under 2.5 days. This is better than the average reported in literature at 3 days, a very low complication rate of 2% compared to 2.5 to 3% within the literature. We also had a very low, we did have one single perioperative mortality, bring our perioperative mortality rate to 0.5%, falling far below the 1.5 to 2.2%. So all in all, given our satisfactory results, we again performed that literature review and proposed an ERAF protocol here. Briefly, this is a super busy slide, but I just wanted to point out that a lot of this, at least the intraoperative realm, falls into the hands of anesthesia. Just kind of stressing the importance of interdepartmental collaboration and especially institutional buy-in. Having a standardized anesthesia workflow would really streamline at least the induction and extubation process, which was seen at least in the same day discharge for craniotomy to hold 2 patients back, not allowing them to be discharged on postoperative day 0. I'm happy to discuss this protocol more to anyone that's interested, but for the sake of time, just briefly glancing at these recommendations here, and they're again available in a study published earlier this year. So conclusions regarding this project and some future directions. LIT is already a minimally invasive and well-tolerated surgery, but there's always room for improvement. Again, this is just a preliminary protocol, and so a prospective study is again warranted for this. This procedure does offer the opportunity for a same-day discharge protocol. We already do biopsies here being discharged in the same day. So it kind of makes sense that we can progress for a same-day LIT discharge protocol. Lastly, patient selection stands to be better defined. A similar process can be taken that was taken with the same-day discharge protocol for this proposed LIT ERAS protocol. And lastly, kind of again, keeping in line with that third tenet of ERAS to integrate new technology, aiming to hasten recovery, advanced imaging techniques such as that of QuickDome can be used for optimal track selection, potentially speeding up the track selection process in the OR with the ROSA arm. And then just very briefly for quality improvement and control, we did perform a study for learning curve with LIT. However, the same sort of methodology and process can be taken at each intraoperative section to kind of track how well our ERAS protocol is being integrated, that being intubation to first incision to MRI to extubation, that sort of thing. Very briefly, I just want to acknowledge all of my mentors here on the screen, Dr. Komatar, Dr. Ivan, Dr. Manzone, Dr. Morel, and all these residents, Dr. Luther, Dr. Liu, Dr. Mondi, and Shovan Bhatia, of course, for their contributions in all of these projects. Thank you very much, and I will now open it up to questions.